Hello? Hello?
Yes, you can start, Dr.
Yeah. Okay. So, hello again. It's a pleasure to see you again in this intensive course, and I hope that you have found till now all the lectures useful in your clinical practice. And this is another lecture, which most of it will be extrapolated from the ESWOF practice guidelines on the role of ultrasound in twin pregnancy. The diagnosis and management of twin pregnancy is a huge chapter, okay? And in the ESWOF guidelines, it is addressed really well. I will share the link in the chat after this lecture so that you, if you have time and a will to go and read them, they are free access, and they're really very well done. As you can see, the diagnosis and management of twin pregnancy includes a huge range of aspects, and I will be dealing with the most practical ones. And in case you have any question at the end of the lecture which has not been addressed, I'd be happy to discuss them after the lecture. So let's start from the beginning of the twin pregnancy. Well, the pregnancy, by a simple question, the pregnancy dating. So we know well how to date the singleton pregnancies, and this has been discussed in previous lectures. What about the twin pregnancy? Well, twin pregnancies should be ideally dated in between 11 and 13+6 weeks, with a CRL between 45 and 84 millimeters. Sometimes we can have a discrepancy between the crown ramp of fetus in twin pregnancy. So in that case, which fetus should we use to date the pregnancy? Well, most of the experts' opinion agree that dating in spontaneously conceived pregnancies, the CRL of the larger twin is the most appropriate one, because if we use the small one or the average, that would probably underestimate the gestation age, and thus we can miss some cases or have a late diagnosis of a case of selective fetal growth restriction. Whereas, of course, if we have an artificially with a pregnancy with an ART, definitely we will use the conception time to date the pregnancy. An important aspect of twin pregnancy, which is key in the prognosis and the management, is the chorionicity. And here it's appropriate to talk about the difference between chorionicity and zygosity. So chorionicity is the number of placenta, okay, and the number of placentas is the main prognostic factor of the outcome of twin pregnancies, whereas zygosity is the number of zygotes. So are the twins, this answers to the question whether the twins are identical or not. And chorionicity is not a synonym to so zygosity and chorionicity are not the same thing, and we'll see why. Well, most twin pregnancies are dizygotic, so they are non-identical, 70% almost, and all dizygotic pregnancies are diamniotic and dichorionic, so they have two sacs and they have two placentas, whereas not all monozygotic pregnancies are dichorionic. This depends on the time in which the separation of the zygotes happens. So if the division of the zygote happens very early pregnancy, we can have a diamniotic dichorionic pregnancy. Okay? If it happens later, we can have a diamniotic and monochorionic. If it's happened even much later, we can have the monoamniotic monochorionic pregnancies, whereas the rare late division of the zygote, which incomplete, can lead to the conjoined twin. So this means that if you have a dichorionic twins, okay, you cannot be sure 100% whether they are monozygotic or dizygotic. However, for the management of the pregnancy, what's important is the chorionicity, not the zygosity. Okay, so how can we determine chorionicity? Well, chorionicity ideally should be determined before 13 plus 6 weeks, so before 14 weeks. And we have many criteria that help us to determine accurately the chorionicity of the pregnancy. So the membrane thickness, the presence of the lambda and T sign, which is the most used and useful sign, and the number of placental masses. Okay, it is extremely important in order to refer the patient appropriately and to avoid confusion later in pregnancy, since it becomes increasingly difficult later in pregnancy to confirm chorionicity, to print a picture which is diagnostic of chorionicity and attach it to the patient file. And in case you are not sure of chorionicity before 14 weeks, you have to send the patient as soon as possible to a referral center, because this little piece of information can change the management and counseling considerably in pregnancy. And this is an example early in pregnancy, okay, between 7 and 9 weeks, in which we can find an accurate diagnosis of the dichorionicity. So you can see in the left-hand side, you can see the very thick, okay, membrane, okay, between the two pregnancies, confirming dichorionic twin pregnancy, whereas on our right hand side we can find an empty, okay, membrane, so there is no placenta, there is no trophoblast. It's separating the two sacs, so this is a diamniotic monochorionic pregnancy. Okay? A little bit later we can confirm the chorionicity by the presence or absence of the lambda sign. So we have this triangular shape of the lambda, like the Y, okay, letter, filled with hyper echogenic material, which is the trophoblast. So this is a diagnostic of a dichorionic pregnancy, whereas in case of monoamniotic, of monochorionic diamniotic pregnancy, we do not see the lambda sign, and we see a thick membrane separating the two sacs, and this is called the T sign. So the membrane is inserted in a T letter sign, whereas in case of dichorionic, we have two placentas, we have the Y-shaped sign. Okay. Beware that sometimes you have a letter which appears like Y, but it has a black content inside it. So this is not the lambda sign. This is called the empty lambda sign, or this is also a T sign. So this is a case of monochorionic, not a dichorionic. Whereas in a case of a lambda sign, the piece, the triangular part of the lambda sign is filled with placental tissues. So on the left-hand side, we have a dichorionic. On the right-hand side, we have a monochorionic pregnancy. This is an extremely important piece of information. A second ultrasonographic aspect in the first trimester that should be diagnosed is the amnionicity. So the number of amniotic sacs. If you are not sure whether this pregnancy is a monoamniotic or a diamniotic, you have to refer the patient. Well, first use transvaginal ultrasound, because transvaginal ultrasound often increases the accuracy of the visualization of the membrane. If you cannot see the membrane. However, you have to refer the patient to a referral center, and it's very important to determine both chorionicity and amnionicity before 13 weeks. And in case of amnionicity, sometimes in case of an early severe twin-to-twin transfusion after 13 weeks, sometimes we do not see the membrane, because if we have a severe oligohydramnios in one of the sacs and polyhydramnios in the other sac, so the membrane can be stuck into one of the twins. Thus, we cannot see it, not because it's a monoamniotic, but because it's a complicated diamniotic monochorionic pregnancy. So the earlier we diagnose the chorionicity and amnionicity, the better. So this a case of again of monochorionic diamniotic twin. So we have we do not have placental tissue separating the two sacs. We have a membrane with an empty lambda sign in these cases. Here on the right hand side we have a classical T sign. Okay, whereas on this is a case of a monoamniotic monochorionic twin pregnancy. So here we can see that both fetuses are included in one sac as early as 9 to 10 weeks. And a sign that is pathognomonic also to diagnose monoamniotic twins is the cord entanglement. Okay, so in case of a diamniotic twin pregnancy, you will never see this entanglement between the two umbilical cords, whereas in a monoamniotic twin pregnancy, this is almost the rule. Okay, so to sum up the chorionicity and amnionicity, ideally we do it between 10 and 14 weeks. We have a lambda sign in a dichorionic diamniotic pregnancy. We have a T sign in a dichorionic this is a monochorionic. Okay, this is an error. So the first one is dichorionic diamniotic. The second one is a monochorionic diamniotic. So this is only one placenta. And the last one is a monoamniotic pregnancy. Once we determine the amnionicity and chorionicity, it is very important to label adequately the twins. Okay, so most centers call them twin 1 or twin 2 or twin A and twin B. Okay? And you have to describe, once you write a report in a twin pregnancy, to try to describe and label each twin by the maximum number of information that you can find. So, for example, you write twin 1 inferior to the left with an insertion of the cord on the lateral side, on the left side, or with placenta that's anterior. Okay, so try just to describe each twin by the maximum number of information. And the parents should know that although we would do our best to label the twins, okay, to know which one will be delivered first, okay, in 10 to 15% of cases, a twin will deliver in an order different from what we labeled prenatally, okay, especially by cesarean section. This is extremely important once you to raise the suspicion that there is a possibility of an inversion of the order of twins, especially when you have a congenital malformation that cannot be seen externally. For example, like one of the fetuses with congenital diaphragmatic hernia, for example. It is extremely important to know that our labeling works well, especially if we use the maximum number of information, but it can be reversed even late in pregnancy. One of the relevant questions to the management of chromosomal of twin pregnancies is how can we screen for chromosomal abnormalities? Okay, so the combined test, so nuclear translucency with the PAP-A and beta HCG with the maternal characteristics, can be used in the first trimester to screen for chromosomal abnormalities in twin pregnancies. Some studies has demonstrated that the accuracy of combined test is slightly lower in twin pregnancies in comparison with a singleton pregnancy. In case of a dichorionic twins, okay, the risk of having one of the fetuses with chromosomal abnormality is the sum of the two risks calculated by the software, whereas in monochorionic twins, the risk of having a baby with chromosomal abnormality is the average of the two risks. Okay? What about cases in which we have a vanishing twin? So if we have a vanishing twin with a measurable fetal pool, okay, it is inappropriate to use the biochemical markers because they may be considerably altered by the presence of the hormones from the vanishing twin in the maternal circulation. So in a case of a vanishing twin, if we have to use the nuclear translucency and the maternal characteristics, but not the biochemical markers. What about the NIPT? Okay, so there are increasing data that at least for trisomy 21, the performance of the cell-free fetal DNA in the detection of trisomy 21 is similar in twin pregnancies in comparison with singleton pregnancy. So NIPT works well for twin pregnancies as well as singleton pregnancies. Okay. Once we diagnose the twin pregnancy, we have to know the plan. So how frequent, okay, should we be seeing women with a twin pregnancy? So the frequency and the instrument that we're using for the follow-up of twin pregnancy differs considerably according to the chorionicity. So in case of a dichorionic uncomplicated twin pregnancy, we have to see the patient first at 11 to 14 weeks. We perform the dating, labeling, we confirm the chorionicity, and we do the screening for trisomy 21. And if everything is okay with the 11 to 14 weeks visit, we can see directly the patient at the time of the detailed anatomy scan, so at 20 to 20 weeks, in which we do the biometry, we measure the amniotic fluid volume, and we measure the cervical length. Then from 20 weeks, we continue to follow the patient every 4 weeks, okay, till the end of pregnancy, and then delivery is usually expedited between 37 and 38 weeks. But the timing of delivery will be discussed at the end, in the last part of the lecture. Whereas monochorionic uncomplicated twins, so uncomplicated monochorionic and diamniotic twin pregnancy is managed much more frequently. So we have to see the patient at 11 to 14 weeks, in which we do the dating, labeling, chorionicity, and the screening. And then we scan the patient every 2 weeks for the whole pregnancy. Before 20 weeks, so at 16 and 18, we do the fetal gross, the assessment of the amniotic fluid, and the umbilical artery Doppler. From 20 weeks on, okay, we do the amniotic fluid, the fetal gross assessment, the amniotic fluid assessment, and the umbilical artery, in addition to the middle cerebral artery peak systolic velocity. And we'll see later what is the rationale of performing also both the umbilical artery and the middle cerebral artery Doppler in cases of monochorionic twins in the regular follow-up of this of the monochorionic amniotic twin pregnancy even if uncomplicated. So one aspect which is quite interesting in the case of monoamniotic twin pregnancy, so in case of monochorionic and monoamniotic twin pregnancy, is the aspect of cord entanglement. Okay? Whereas earlier in the scanning of monoamniotic twins, many studies has raised concerns about seeing two cords that of the two twins in a monoamniotic twins which are entangled. Okay, this can be seen both by color Doppler and by pulsed wave Doppler, in which we can see in the same two frequencies of the fetal heart rate, meaning that the two cores are touching each other and they're entangled. The most recent studies has demonstrated that cord entanglement is the rule, so it is not an additional risk factor in case of monoamniotic twins, but it's almost always present, and by seeing it or not seeing it does not increase the risk of perinatal complications in case of monoamniotic twins. Okay, definitely the case in case of monoamniotic twins need more intensive follow-up in comparison with the monochorionic diamniotic twins. The real problem of the monoamniotic twins is the sudden intrauterine fetal death. Okay, so it's most of the complications in case of monoamniotic twins are sudden and unexpected. Okay, so we have to increase the follow-up, but it is questionable whether the complications can be predicted or not even by close follow-up in cases of monoamniotic twin pregnancy. It's also questionable whether these patients should be managed in inpatient regime or by an outpatient regime. Some studies has found that managing patients with monoamniotic twins after 20 weeks in an inpatient regime may be associated with a slightly reduced risk of intrauterine fetal death. And then we have to the timing of delivery is by cesarean section, and is recommended between 32 and 34 weeks. Although some centers, especially in France, do deliver women with a monoamniotic twin pregnancies at 36 weeks, because it seems that the vast majority of complications do happen between 32 to 33 weeks, and it seems that after 33 weeks, it's very uncommon to have a complication of a monoamniotic twin. Another interesting aspect is the prevention of preterm birth. So one of the main problems of twin pregnancies is the risk of preterm birth, whether spontaneous or iatrogenic. It has been discussed for a long time, and actually it is still a matter of debate, how to prevent the preterm birth in twin pregnancies. And the problem with twin pregnancy is that almost all interventions seem to be inefficient or sometimes even harmful in case of twin pregnancies. Very recently, there has been some little update on this specific aspect. First of all, which cutoff should we use for the cervical length to label a patient as a high risk of preterm birth in a twin pregnancy? It seems that the best cutoff to be used in a twin pregnancy is a cervical length less than 25 millimeters. And in a recent meta-analysis, it seems that it has been concluded that if you have a twin pregnancy and cervical length less than 25 millimeters, that progesterone in whether 200 milligrams per day, or once or twice per day, okay, till 34 to 36 weeks, reduces slightly the risk of preterm birth. So now it is plausible and explainable to and reasonable to screen, to measure the cervical length in the second trimester scan in twin pregnancy. And if we have a cervical length less than 25 millimeters, it is advisable to give progesterone. This is a very recent study that has been published on the American Journal of Obstetrics and Gynaecology, and in that case, the women were not classified as a high risk or low risk according to the cervical length, but according to cervical examination, clinical examination. So if by digital examination, the cervix was found between 1 and 5 centimeters, okay, women were randomized to to do or not a cervical cerclage. And it seems that in that study, actually it was stopped due to a clear efficacy of the physical examination indicated cerclage. So in case of a physical examination in which you find a cervix dilated between 1 and 5 centimeters, now there is data that says that a cerclage, okay, is improves the outcome, so it prolongs the pregnancy and reduces the perinatal morbidity and mortality. Okay? And very important and also debatable aspect of the assessment of twin pregnancy is the assessment of biometry. So in the second trimester, so in the first and the second trimester, the growth of the singleton and twin pregnancies are usually overlapping, whereas in the third trimester, from 30 to 32 weeks, there is a clear difference between the growth of twins and singleton pregnancies. So this raises the question of which growth chart should we use. Okay, so we know that twins grow less in the third trimester. So shall we use the singleton charts or shall we use the twin charts? Most experts advocate that using the singleton growth curves is more appropriate, because twin pregnancies are in the third trimester are often growth restricted. So by using the twin pregnancies charts, we may be underestimating considerably the problem of a fetal growth restriction in twin pregnancy in the third trimester. So we use the singleton growth curve, and most of the centers worldwide do use the singleton charts to define the growth of twin pregnancies. And an important topic to be diagnosed and managed in case of twin pregnancy is the selective fetal growth restriction. And whereas the term selective fetal growth restriction is classically exclusive to a monochorionic pregnancies, sometimes it is extended also to a dichorionic twins. So in case of a dichorionic twin, having a selective fetal growth restriction means that you have one fetus with an estimated fetal weight less than 10th centile. Whereas the classical selective fetal growth restriction of the monochorionic twins, this is a combination of having a fetus with a birth weight with an estimated fetal weight less than the 10th percentile and a discrepancy of the estimated fetal weight of more than 25%. Okay, so how do we calculate the discrepancy between the twins? It is the fetal weight of the large baby minus the estimated fetal weight of the small baby, and divided by the estimated fetal weight of the big twin multiplied by 100%, by 100. Okay, so the large minus the small divided by the large multiplied by 100 by 100. This discrepancy, if it's more than 25%, it is associated with a higher risk of complications. Recently, it has been published a Delphi paper, which is practically is a consensus between the largest number of experts worldwide, and it's usually defines some definitions. So it has been agreed that to diagnose a selective fetal growth restriction in a dichorionic twins, as if we would like to use only one characteristic, it is better to use the estimated fetal weight less than the 3rd percentile, whereas if we want to use more than one characteristic, if we have at least two out of 3 characteristic of having an estimated fetal weight less than the 10th centile, and discordance of the weights more than 25%, or an abnormal umbilical artery Doppler, okay, any 2 of the 3 criteria diagnoses a selective fetal growth restriction in a dichorionic twin pregnancy, whereas in a monochorionic twin pregnancy, if we would like to, if you have only an estimated fetal weight less than the 3rd percentile, this is diagnostic, or if you have any 2 of the 4 characteristics of having an estimated fetal weight of one twin less than 10th percentile, abdominal circumference of one of the twins less than the 10th percentile, an estimated fetal weight discordance more than 25 percentile, and an abnormal umbilical artery Doppler. Okay? So this has changed a little bit, extended the definition of the selective fetal growth restriction, both in dichorionic and monochorionic twins. So how do we manage a pregnancy with a selective fetal growth restriction? Well, in case of a dichorionic twin pregnancy, the management is similar to a singleton pregnancy. So you deliver you follow up the pregnancy, and the indication of delivery is similar to a singleton pregnancy. You do a biometry and Doppler every 2 weeks, including the umbilical and middle cerebral artery Doppler. Whereas in monochorionic twin pregnancy, we don't really have a huge evidence on how the best management protocol, but seeing these patients at least once weekly, okay, with a biometry every 2 weeks and Doppler at least every 1 week, with an umbilical and mid-cerebral artery Doppler, and including the ductus venosus in cases of an abnormal umbilical artery Doppler, seems like a quite reasonable approach. How do we manage selective fetal growth restriction? Well, in case of monochorionic twins, the options include conservative management, laser ablation or cord occlusion of the small fetus to protect the co-twin, and this is usually opted for if we have a very high risk of fetal demise before 26 weeks. Okay, so we'd like to whether to ablate the anastomosis between the 2 fetuses, or to occlude, so do a selective termination of 2 of the small fetus. And our fear is this kind of complication. So what happens if one of the 2 fetuses dies in utero? Well, there is a huge difference between the risk of complications in the case of a monochorionic and dichorionic twins. The main problem is that fetuses with monochorionic twins do share the same circulation. So if you have a fetal demise of one of the 2 fetuses, there is a high risk of having a severe hypotension in the surviving twin, with a high risk of death, and above all, of neurodevelopmental impairment. So if you have a death of one of the co-twins in a monochorionic twin, the other co-twin will die in 15% of cases. The rest in 70% will need to have to deliver prematurely. In about 1/3, they will have an abnormal cranial imaging, and 1 out of 4 fetuses of the surviving co-twins in a monochorionic couple will have a neurodevelopmental impairment. And this is extremely important once you counsel a couple with a monochorionic twin pregnancy, especially if you have a high risk of fetal demise, or and also after the fetal demise. Okay? The couple, they have to know that in case of a death of one of the co-twins, the other have a high risk of having a brain damage, and that expedite and swift delivery usually is not indicated, because the damage, once the other baby is dead, the damage has already happened. Okay, so it's not advisable to expedite, to have a very premature delivery in case of the death of the one of the monochorionic couples, because this does not seem to improve further the outcome. We continue to follow them up in case of a conservative management every 2 to 4 weeks, and the delivery is expected between 34 and 36 weeks. There is a specific classification for the selective fetal growth restriction in case of a monochorionic twin pregnancy, and this is based on the Doppler, the umbilical autodoppler. So if we have a normal Doppler, okay, this is the type 1 selective fetal growth restriction. If you have a persistent abnormal Doppler, so abnormal, high, or absent or reversed end-diastolic flow, this is type 2, whereas there is a specific type, which is type 3 according to Gratakos, in which there is an alternation of the normal and abnormal umbilical autodoppler. Okay, so it's a pattern which happens also in monochorionic twin pregnancies, and it may happen very early and persist till delivery. The problem with having the type 3, which is the intermittent cyclical absent or reverse end-diastolic flow, is that intrauterine fetal death may happen, and it's almost always unexpected. So there is no gradual deterioration in the worsening of the pattern. And here, not only the small baby is risking, so the small baby is risking intrauterine fetal death, but also the larger twin is of risk of cerebral damage due to a sudden and continuous hemodynamic instability. Okay, so up to 20% risk of having a brain damage in the large twin. So this is a case of selective intrauterine growth restriction. So there is a large baby and small baby, and you see how the Doppler changes from a reversed end-diastolic flow, okay, to absent end-diastolic flow to present end-diastolic flow, and then again absent. Okay, so this is a cyclical intermittent absent or reversed end-diastolic flow, which is type 3 selective fetal growth restriction in monochorionic twins. A specific complications also of specific to monochorionic twins is the twin-to-twin transfusion, and this is due to large anastomosis between the two twins, and imbalance, hemodynamic imbalance of the distribution of the circulation between the two twins. So there is one twin who is a donor, giving too much blood to the other, and another one which is a recipient, which is receiving a large amount of share from the placenta. And the diagnostic criteria prenatally is the presence of oligohydramnios in the donor. okay, and which is defined of a maximum vertical pocket less than 2 centimeters, and polyhydramnios in the recipient, which is defined as 8 or more centimeters less than 20 weeks, and 10 or more centimeters in more than 20 weeks. Any discrepancy in the amniotic fluid not respecting this strict criteria is associated with a much better outcome than the classical definition of the TTTS. Other criteria, and I will show some videos on how other criteria that can be used to whether to diagnose or to classify the TTTS, is the bladder side discordance, the folding of the amniotic membranes, and the alteration of the Doppler. So this is a case of TTS with a normal bladder in one of the fetuses and in the recipient, and a very small bladder in the donor. And this is a case of in which the liquid amniotic fluid is objectively normal in both sacks, but there is a huge folding in the membrane, okay, denoting the on the left hand side the donor twin, and on the right hand side you have a slight increase in liquid, although they did not have the strict criteria of the TTTS. The Doppler management of the TTTS twins is extremely important, and usually the donor twin tend to have an absent or reversed end-diastolic flow, whereas the recipient tend to have alterations of the ductus venosus, so absent or reversed A wave in the ductus venosus. This is the famous Quintero staging, which continues to be a valid classification of the TTTS. So stage 1, if you only have the amniotic fluid discrepancy. Stage 2, if you have a bladder of the donor which is not visible. Stage 3, if you have an umbilical Doppler alteration, or a ductus venosus or umbilical vein alteration. So if you have an absent or reversed umbilical artery diastolic flow, or reversed ductus venosus A flow, or a pulsatile umbilical venous flow in either of the twins. Stage 4, if you have a hydrops of one of or both twins, and stage 5 is the death of one or both twins. The treatment of TTTS is the most appropriate management before 26 weeks is laser ablation of the anastomosis. Expectant management or laser ablation of the anastomosis may be considered also in Quintero stage 1. So from stage 2 onwards, the best treatment is laser, and it's still a matter of debate what is the best treatment management for the stage 1. And the main problem is that stage 1, in about 30% of cases, it may progress from stage 1 to worse stages, although there is no definitive evidence on which is the best management option in case of stage 1 Quintero staging TTTS. Another specific complication of the monochorionic twin is the twin anemia polycythemia sequence. So this is different from the twin-to-twin transfusion, because in the twin-to-twin transfusion, there is a hemodynamic imbalance between the two fetuses, but the hemoglobin of the two fetuses is the same. So there is a circulation of the blood through large anastomosis between the two fetuses, so it's diluted, so the hemoglobin concentration is the same in the two fetuses, although there is a hemodynamic imbalance. Whereas in the twin anemia polycythemia sequence, okay, there is a significant difference between the hemoglobin. So there is one of the fetuses which is polycythemic, and the other which is anemic. It can happen whether spontaneously or as a complication of a twin-to-twin transfusion, and it is due to very small, less than 1 millimeter AV anastomosis that allow only slow blood transfusion from one to the other without having a large anastomosis that compensate for this small passage. And the diagnostic criteria is one of the fetuses, who is the recipient, having a the donor has a high velocity in the middle cerebral artery. So we have a middle cerebral artery peak systolic velocity higher than 1.5 mom, and the other fetus has a middle cerebral artery peak systolic velocity less than 1 mom in the recipient. Postnatally, it is diagnosed by having a discrepancy of hemoglobin more than 8 grams, and actually usually it's a spot diagnosis. We have a baby who's extremely red, almost violet, and the other one who's extremely pale. Okay, and whereas in the postnatal diagnosis is having a reticulocyte count ratio between the two fetuses more than 1.7, and having a placenta with only with small vascular anastomosis. This is the staging of the TAPS of the twin anemia polycythemia sequence, which depends on the Doppler. So stage 1 is we have only the diagnostic criteria more than 1.5 mom and less than 1 mom. Stage 2 more than 1.7 mom in one of the two fetus and less than 0.8 mom in the other fetus. Stage 3 if you have a cardiac compromise or critically abnormal Doppler flow. Stage 4 hydrops, and stage 5 intrauterine fetal demise. Okay. And postnatally, it depends of the intertwin difference. So the higher the intertwin difference of the hemoglobin levels, the higher the stage. What are the outcome of TAPS? So in many cases, if they are delivered surviving, they have a good outcome. Often the donor has a severe anemia and needs blood transfusion, and sometimes he's so anemic that the baby can develop cerebral damage, whereas in the recipient many cases go without specific severe complications. And although severe polycythemia, thrombocytopenia, limb ischemic necrosis in some cases, and cerebral damage may happen. This is the last specific complication that we'll discuss in the TRAP, in the monochorionic twins, which is the TRAP twin reverse arterial perfusion sequence. And it's a very rare complication of monochorionic twins. And it consists in having a baby, a normal baby, and the other one who is a cardiac mass. So it's a fetus without a heart and totally perfused by the normal twins, leading to an extreme overload of the fetal heart of the normal baby. So how should it can be treated? As early as possible, usually best less than 16 weeks. Should be performed cord coagulation, cord ligation, or photocoagulation. So we have to block the circulation of the acardiac mass to avoid the demise of the normal baby. So this is a case of TRAP. This is the normal baby with the beating heart, normally growing. And then we have on the other side a small mass, okay, of a moving baby, but with no heart. And here we can see the acardiac mass, which is perfused, okay, by the other circulation baby, the circulation from the other baby, although there is no heart in this mass. And this is a glass body reconstruction of, this is on the left hand side, the small baby, the normal baby with a normal circulation heart, and the other mass which is only perfused passively from the normal fetus. So this is the last part of the lecture, the timing of delivery. So there is slight difference between the various societies, but it's not really clinically relevant. So in an uncomplicated dichorionic diamniotic twins, the delivery should be between 37 and 38 weeks. In monochorionic diamniotic twins, the recommendation is between 34 up to 37 weeks. In monochorionic monoamniotic twins, the delivery should be undergone between 32 and 34 weeks. Okay? This is in case of uncomplicated, whereas in case of complicated monochorionic twins, in case of selective fetal growth restriction type 1, usually it's recommended to deliver the babies at 34 to 36 weeks. In type 2 and 3, usually they're delivered at 32 weeks or before if we have a ductus venosus abnormalities. Whereas in case of twin-to-twin transfusion, the delivery is recommended at 34 weeks. So this ends the lecture on the twin pregnancies, and I'll be happy to have any questions on the lecture. I have just to find the questions. Okay. I cannot see any questions for now. I'll wait for a few seconds. Okay. How do you label twin 1 and twin 2? Dr. Adil Ashraf is asking. In our clinic, we label twin 1 the closest to the cervix, and twin 2 the higher one. So the inferior twin, we call it twin 1, and the higher twin, we call it twin 2. This is not always feasible because sometimes you have it's really difficult because you have the two fetus sometimes during the same examination. Okay, sometimes you have one lower and one higher. Okay, so here we label them according to we follow the classification done by the first operator. Okay, so the first operator chooses here, if you don't have one higher and one lower, you choose twin 1 and twin 2 with no specific criteria. But once you describe twin 1, you say, well, twin 1 is on the left-hand side of the left of the patient. Okay, the sac is a little bit more inferior. The placenta is inserted where the placenta is inserted. If it's one placenta, you say where is the cord is inserted. Yeah, and in case of monochorionic twins, and if you have a different gender of the babies, you specify the gender. Of course, if we have the baby, smaller baby or larger baby, if you have a selective growth restriction, you add it. Okay, so we use the maximum number of information, and we tell the patient that very rarely, it's uncommonly, but it may happen that the classification that we do now would be different at delivery. The classification in case of monoamniotic twins is extremely difficult unless you have one baby with a malformation. Otherwise, it's extremely challenging to call the babies in a case of monoamniotic twins. Okay, this was the only question that we have in the lecture. Yeah, I'll share immediately now with you in the chat the link of the ISO guidelines. I tried my best to answer the most critical aspects of twin pregnancies management and diagnosis, but it's quite difficult to cover totally. So I'm sharing in the chat box the link to access directly the free access guidelines on the twin pregnancies. Okay, thank you, Dr. Poonam. Okay, I'll go to the next lecture, which is, we're moving quite out of the topic of prenatal management, and it's a topic which I think, although it's it does not deal with prenatal diagnosis. I think that it, as you'll see, it touches the life of a huge number of women, okay, who otherwise their symptoms tend to be underestimated, and they do not really find a relief often in the practitioner's service. Okay, so it's about the pelvic floor. I'm fond of 3D ultrasound, and although I'm a fetal and prenatal medicine consultant, I've been now for many years been intrigued and attracted by how 3D ultrasound in the pelvic floor, differently from the 3D ultrasound in prenatal medicine, can be really clinically useful. I'm sure that most of you, I don't know if there are radiologists or there are sonographers in the course, but I'm sure that many of you are obstetricians, as has been practicing in the labor ward. And we know once we have the crowning of the fetal head, the head is going out, most of our problems will not we see them far, okay? Although for many women, the time of delivery is just the beginning of a series of problems correlated to the pelvic floor. Okay, and although our understanding of the pelvic floor problems are increasing, I can say thanks at least partially to the development of the 3D ultrasound of the pelvic floor. So we are understanding better and better the correlation between vaginal delivery and pelvic floor dysfunction. Women do know that for a long time. So the pelvic floor symptoms were present. And the problem is that many women were just silenced, or their symptoms were underestimated and simplified. So many women thought that having urinary incontinence or a rectal incontinence, or having a considerable prolapse when she has 35 years is a normal consequence of vaginal delivery. With the increased awareness, the increased discussion on the topic, and the change in the women's lifestyle definitely is changing this aspect. So a very relevant question has been asked by Codwell Hall, which is a collaborator of Professor Hans-Peter Dietz in Sydney, Australia, who's I would consider the father of the ultrasound of the pelvic floor, of 3D, especially 3D ultrasound of the pelvic floor, and tried on the basis of some objective information to see how many women get what they want from the delivery. And they hypothesized that women do not want to have an instrumental delivery, do not want to have an obstetric anal sphincter injury, and do not want to have an ultrasonographically diagnosed levator ani avulsion, which is detachment of the levator ani muscle from its insertion, or sphincteric damage diagnosed by ultrasound. And in the second model, they hypothesized that women do not want also a microtrauma of the levator ani muscle, which is defined as a loss of tone of the levator ani muscle. Both avulsion and microtrauma are significant risk factors of developing a pelvic organ prolapse. And by doing these two models, they have found that in their population, only 40% of women will get what they want, and including the second model, only 1 out of 3 women will get what they want from vaginal delivery. So this raises actually a question of what are the outcomes that should be considered for a successful vaginal delivery, and what are the outcomes that should be considered to follow up and to assess the performance of a labor ward. By doing just two calculations, this means if we consider accept that the model suggested by Codwell Hall correct, this means that only today, okay, in the next 24 hours, almost more than 170,000 women will not get what they want. Okay, so we know that many women do suffer from significant perineal lacerations in the labor ward, but this is not the whole story. Okay, because in the labor ward we can diagnose a lot of lacerations, but they're almost all superficial from a muscular point of view. So we can see the perineal skin only in the first degree. We can see the perineal, so superficial and deep transverse perineal muscles. In the second degree, the anal sphincter in the third degree, and the anal canal in the and epithelium in the fourth degree. But there is an important muscle, which is the levator ani muscle, which is impossible to visualize and diagnose accurately in the labor ward. And the inner part of the levator ani muscle is the green part, which is the puborectalis muscle. The puborectalis muscle and the levator ani muscle gets stretched by the fetal head up to 3 times its length. And we know from physiological studies that if a striated muscle gets dilated by more than 30% its length, it has a high risk of developing an irreversible damage. So actually, the levator ani muscle, it's miraculous that it does not develop permanent damage in all vaginal deliveries, but we will see what is the risk of having a damage to the levator ani muscle in a vaginal delivery. So the levator ani muscle is a sheet, okay, and the inner part of this sheet is surrounding the pelvic structure, so the urethra, the vagina, the rectum, okay, they are all surrounded by the inner part of the levator ani muscle, which is the puborectalis muscle. Yeah. What happens in a case of an unfortunate vaginal delivery? What happens? It's the main common damage of levator ani muscle in the labor ward is what's called levator ani avulsion. A levator ani avulsion is a detachment of the levator ani muscle from its insertion on the pubic rami. So this is where the damage happens, and we'll see by how ultrasound contributed to our understanding to the function and integrity and damage, potential damage of the levator ani muscle. We will start talking about the 2D technique, and we'll discuss why a 3D ultrasound relevant and important technique to assess the levator ani muscle. We will try with the permitted time to talk about the technique of acquisition and analysis of the 3D volumes acquired from the pelvic floor, and we will lastly talk about the effect of pelvic floor dimensions and function of the outcome of delivery, because we now are understanding that not only the vaginal delivery has an effect on the pelvic floor, but also that the pelvic floor dimensions and function are necessary to obtain a good outcome from the vaginal delivery. So what are the clinical relevance of the pelvic floor lesions? We, first of all, the incidence. 1 out of 4 women approximately in their first delivery will have a damage to their levator ani muscle. And there are some risk factors that we do know, like an increasing maternal age, forceps delivery, a prolonged second stage of labor, women who have a small hiatal area, so the small dimension of the area included inside the puborectalis muscle, have a higher risk of developing or undergoing a damage of the levator ani muscle. Some studies have found that epidural analgesia may be protective against the damage to the levator ani muscle, although not all studies have found it. And we have recently demonstrated that cristellar maneuver, which is the fundal pressure in the second stage, is associated with more than a doubled risk of having a levator ani avulsion. So actually, even when correcting for other confounding factor like epidural analgesia, fetal weight, and the duration of the second stage. So the cristellar maneuver is an independent risk factor for having elevator ani avulsion. As an obstetrician, I think that it's this, we should not conclude from this study that cristellar maneuver should be banned or it should be illegal. Okay, although it's definitely, this raises concerns regarding the maneuver, which is often used almost routinely in many labor wards around the world, and it's considered as a part of a physiological delivery. So I think that banning or illegalizing the procedure is not appropriate, but also using it as a routine or as an allegedly harmless maneuver is not appropriate too. What are the consequences of having a damage of the levator ani on the pelvic floor, levator ani avulsion? Well, a damaged muscle has a reduced activity, definitely, but the most important association in the literature is between the damage of the levator ani muscle and pelvic organ prolapse. So women who have a levator ani avulsion seem to have a doubled risk of developing prolapse. The larger the avulsion, the more severe and the more frequent the signs and symptoms of prolapse. Women who have a bilateral levator ani avulsion have even a higher risk of prolapse, and women who have a levator ani avulsion undergoing surgery for pelvic organ prolapse have a much higher risk of recurrence if they do, in comparison with women who have an intact levator ani muscle. How can we diagnose levator ani avulsion? Well, clinically, if you go with your the finger lateral to the urethra, push laterally, and ask the woman to contract her pelvic floor, many clinicians can feel the levator ani muscle, but it is not a reliable and reproducible technique to diagnose levator ani avulsion. MRI can be used, but it's an expensive method. It's not done by gynecologists, and it is not easy to assess the dynamic part of the pelvic floor using MRI. Ultrasound, the transperineal ultrasound using the convex transducer, whether 2D if you would like only to have 2D information, or the 3-dimensional convex probe, the regular one that we use in our daily practice, is the transducer that we use. Okay, you put a lot of on the transducer, and then you cover the transducer by a glove, and then you put a generous quantity of gel on the delivery on the glove, and then you have your transducer ready to use. Ultrasound of the pelvic floor, the transperineal ultrasound to visualize the levator ani muscle, is done in the mid-sagittal view. And in order to imagine what are the structures that you will see in ultrasound, you have just to imagine the pelvic floor inverted. So from left to right, you will see the symphysis pubis. This is the bladder with the urethra, the vagina, the rectum, and then you have the puborectalis muscle passing behind the anorectum, creating this anorectal angle. An extremely important aspect and relatively simple aspect of pelvic floor ultrasound is the 2-dimensional dynamic evaluation. And this can give you very important information regarding both the contraction of the pelvic floor and the relaxation of the pelvic floor. So women should be able to contract the pelvic floor because the tone of the muscle is responsible of the respective and appropriate anatomy and relationship between the various anatomical structures, and also on the continence. Whereas the relaxation is very important, whether for voiding, for defecation, and for vaginal delivery, as we'll see later. And once you ask the patient to contract her pelvic floor, as she's doing the Kegel exercise, so she's the contraction of the pelvic floor, what happens is that the levator ani muscle, the puborectalis passing behind the rectum, would pull the rectum toward the symphysis pubis. So this can be used for a visual feedback. And actually, this is a practice that you can start doing from tomorrow, okay, in your clinical practice by placing the transducer, asking the patient to contract, train her to contract her pelvic floor. Any woman who has given birth, or even more importantly, if she have any pelvic floor dysfunction symptoms, whether incontinence, urinary incontinence, prolapse, or rectal incontinence, can benefit from an appropriate pelvic floor exercises. The problem is that many women are not able to contract their pelvic floor, and visual feedback can be very helpful. Whereas in case of Valsalva, so we ask on the right hand side, if you ask the patient to push, again, not all women are able to push, relaxing the pelvic floor. A woman who is able to relax her pelvic floor, when she pushes, the rectum and the respective puborectalis muscle should move to the right. This means that she's increasing her anteroposterior diameter of the levator hiatus. And very recently, finally, we had a classification of normality. So what is a normal pelvic floor muscle contraction? And we now know that any woman, when you ask her to contract her pelvic floor, she should be able, in case of a normal contraction, to reduce the anteroposterior diameter of the pelvic floor of the levator hiatus, which goes from the lowermost part, so the part of the right of the symphysis pubis, and the most protruding part of the puborectalis muscle. This is the anteroposterior diameter of the levator hiatus. This diameter should be reduced from rest to maximum contraction by at least 15%. Okay, so any reduction be less than 15% is a weak contraction, according to the recently published study by Neos and colleagues. So now we have seen that by 2D ultrasound, you have a lot of useful information. So why do we have, or do we need 3D or 4D ultrasound? The problem with 2D ultrasound is that you get only a midline vision. So you don't have a three-dimensional vision of the whole muscle, because it's an impossible plane to get by 2D ultrasound. In addition, the plane of the levator ani muscle is a thick plane, and it is warped. As you have seen in the beginning, the levator ani muscle is not a flat sheet, it's a curved sheet. So it's impossible to see by 2D ultrasound. By 3D, or well, the difference between 3D ultrasound and 4D ultrasound is that the 4D ultrasound is a three-dimensional reconstruction in time. So you can see movement by 4D ultrasound, whereas 3D ultrasound gets static images. And it's very important, although the technique from a practical point of view and from a technical point of view is the same, we need 4D ultrasound in the pelvic floor because we need to assess the dynamic aspect of the pelvic floor. What we need is to reconstruct the plane of the levator ani muscle, which runs from the symphysis pubis till the anorectal angle. The criteria of acquisition are you have to always have a wide angle of the acquisition. You have to get a high quality of the acquisition, and this is the plane that you need to reconstruct, which is almost always a little bit oblique. Okay, this is why you have to use whether to rotate the plane of the levator ani muscle, or use a technique that can trace an oblique plane. And if you get that, you will see the pubic rami, urethra, the vagina, the rectum, and this structure traced by the on the screen is the inner side of the levator hiatus, included inside the levator ani muscle. So once you get the volume, we'll have a multiplanar mode. The A plane is the mid-sagittal acquisition plane. The B plane is the coronal plane, whereas the C plane is the plane parallel to the ultrasound transducer, which is the one which should be reconstructed. And it can be reconstructed whether by a box, the render box, which has to have the criteria of being thick between 1 and 2 centimeters. Okay? The render technique should be, if you have the machine that you preset machine, you can choose tissue. Otherwise, it should the proper mix of the render should be 80% X-ray and 20% surface. Okay? But this is only a very specific detail, which makes the quality of your images better. But most of the reconstruction technique will give you an appropriate measurement, an appropriate visualization of the levator ani muscle. You should do the dynamic assessment of the levator ani muscle, whether as with contraction. So you see in the render contraction here, the contraction from rest to maximum contraction, you see how the levator hiatal area is reduced considerably. Whereas if you ask the patient to push, normally the levator hiatal area should distend, okay, in an appropriate valsalva. The technique that we use in our clinic is the linear reconstruction technique. Okay? So we, for example, use it in case of the brain if you don't have the midline appropriately horizontal. Okay? Whether you rotate the midline to make it horizontal, or you can just trace by the linear reconstruction technique, what's called in some machines OmniView or OVIX in some other machines. So with a thickness of, in the case of the pelvic floor, 10 to 20 millimeters. So what happens is just we have to trace the plane that we want to reconstruct, and we have an automatic real-time reconstruction and rendering of the pelvic floor structure. Okay. Again, by tracing this line is not only on 3D static images, but also as an acquisition plane in 4D. You can activate the 4-dimensional technique, trace the line, use the maximum angle, activate the VCI, so the contrast enhancement technique for between 1 and 2 millimeters, and then if you ask the patient to contract and push, you will have the reconstructed muscle visualization in real time. What should we see on the level of the levator ani muscle? So there are 2 damages that, as we discussed in the beginning of the lecture. The first one is an avulsion, so it's a macroscopic detachment of the muscle from its insertion of the pubic rami. The other damage is a microtrauma. Microtrauma is a muscle which lost its tone. So you ask the patient to push, and then you have a huge dilatation and ballooning of the levator hiatus. Regarding the integrity of the muscle, ideally, you should use the tomographic ultrasound imaging, so the multi-slice technique with a 2.5 millimeters inter-slice thickness. And in order to be sure that you are on the right plane, okay, and you have to see on the central 3 images, on the first one, some space between the pubic rami. On the second slice, you have to see some space, but it's closing between the pubic rami, whereas in the third image, you should not see any space between the pubic rami. This is a quality control check of your appropriate reconstruction of the muscle. And here you can see another example of a perfectly intact muscle, whereas here a case of a detachment. So there is a lack of a continuity of the muscle in on our left hand side, which is the right muscle, the right hand side muscle of the patient. This is another case with a significant avulsion, again on the right hand side of the patient. And actually, this defect can be quantified in case like this one. Actually, you don't really need to measure anything because it's obvious that the muscle is totally detached. But in some cases, you may have some doubts. So objectively, the space between the center of the urethra and the nearest identifiable part of the muscle near the pubic rami should be less than 25 millimeters. If it's larger than 25 millimeters, it's defined as an avulsion. In order to define a complete avulsion of the levator ani muscle, which is the significant ultrasound finding, you have to find the defect present in all the three central images. Otherwise, it's a partial avulsion. And this is how you see the micro trauma or the ballooning of the levator ani muscle. You ask the patient to push, and then you have a levator hiatal area more than 25 centimeters square on maximum Valsalva. The last part of my lecture is regards the effect of the pelvic floor on the outcome of delivery. So now we have seen what can we identify in the pelvic floor as a consequence of vaginal delivery. But the other question is the pelvic floor important for the outcome of delivery? Okay. So we have seen that the Valsalva maneuver, so pelvic floor relaxation, is important in order to increase the pelvic floor dimensions. And this is relevant for the childbirth, for vaginal childbirth, because adequate pushing in the second stage of labor is characterized by a pelvic floor relaxation and an increase in the intra-abdominal pressure of the patient. So a combination of the pushing and from up and the relaxation from the levator ani muscle point of view. How can we see the levator ani muscle in pregnancy? So again, the regular structure, the pubic symphysis, the urethra, the vagina, the rectum, and the pubic muscle. And you can see here the fetal head. The dimensions and the function of the levator hiatus can be, we can use the anteroposterior diameter as an index of the relaxation. So in a case of a woman who is contracting her levator hiatus muscle, you see how the outlet, the gate from which the fetal head should go out is reduced. Actually, in that case, the woman, once she contracts her pelvic floor, the fetal head goes up, so it goes higher in the pelvic floor. Whereas on the right-hand side, you can see the patient who's pushing. Both these images are before the onset of labor. Okay, so a woman, even before the onset of labor, if she pushes adequately, increasing her levator hiatal diameters, this is associated with a descent of the fetal head in the birth canal. So what we examined actually in our center is first of all the association between the pelvic floor diameter, the anteroposterior diameter, and the mode of delivery, and the anteroposterior diameter and the duration of the second stage of labor. And we have seen that the shorter the anteroposterior diameter of the levator hiatus, both at rest and at pushing, the longer is the active second stage of labor. So women who have a smaller hiatal dimensions tend to push for longer period in comparison with women who have a larger pelvic floor diameters. All our studies were conducted on nulliparous women, so women who are about to get their first vaginal delivery. And what we have also, we were very curious and interesting to study is a phenomenon called the levator ani muscle coactivation. What is the levator ani muscle coactivation? Well, normally a woman, if she pushes and relaxes her levator ani muscle, the anteroposterior diameter of the levator hiatus increases. Whereas on the left, on the right, your right hand side, this is a woman who's pushing with the phenomenon of levator ani coactivation. This means that with pushing, she's contracting her pelvic floor muscle. And what happens that she's pushing, the fetal head is trying to get down, but the muscle of the levator hiatus is moving to the left. So this is a woman who is coactivating, so contracting her levator ani muscle rather than relaxing it during the Valsalva maneuver. And we have found that in nulliparous women with coactivation, after correcting for maternal age, BMI, and epidural analgesia and birth weight, they had a longer second stage of labor, whether in case of spontaneous onset of delivery. And this was confirmed also in another study in which we assessed the pelvic floor before the onset of delivery of labor in women undergoing induction of labor. And again, we have found that coactivation was associated with a longer second stage of labor. Lastly, we have demonstrated that women with the larger the pelvic floor diameters at term, the lower and the more engaged is the fetal head. So this is actually a new field in which we're still exploring a lot of aspects, but our aim and our perspective is to try and find a tool to help women undergoing vaginal delivery in order to better relax their pelvic floor, whether by visual feedback, whether by coaching in labor, whether by physiotherapy or education before the onset of labor. There are no data yet on this specific aspect, okay? But we think that women who are coactivating or women with small levator hiatal diameters are good candidates to be assessed for this aspect. And actually, we know from our experience and our data that we can help women to better relax their pelvic floor, okay, by visual feedback. So we asked the woman, this is the same woman with a 1 minute difference between the two videos. So on the left hand side, we have a woman who's coactivating, and then we instructed her that no, you are contracting. Look at the muscle. If it moves to the left, you are contracting. Try to relax, okay, when you push. And then she tried at least partially to correct for this coactivation. So she pushes and then contracts. She feels it and sees it, and then try to relax. And this is a cycle of improvement of the levator ani muscle coactivation. Visual feedback is not useful in all cases of coactivation. From our experience, between 15 and 25% of women with coactivation can be helped by visual feedback. Okay, so this is the last part of the lecture regarding the visualization of the anal sphincter. So to see the anal sphincter in the labor ward, ultrasound is not useful, but after delivery, at least 2-3 months after delivery, by using the axial angulated technique, you can see actually the anal sphincter. This is the anal canal. This is the black ring is the internal anal sphincter, and then the hyperechogenic gray ring around the internal anal sphincter is the external anal sphincter. Okay, there are some signs that can be seen by ultrasound suggestive of anal sphincter damage. So this is at the level of the anal canal. The star sign. The star sign is an index of a proper tone of the anal sphincter. The absence of the star sign is a sign of a sphincteric injury. Here we have an external sphincteric damage. So we have a discontinuity of the external sphincter. In that case, we have a half moon sign, so we have an intact external sphincter, but we have a missing part of the internal anal sphincter. So to sum up, the pelvic floor ultrasound is a reproducible and reliable tool to assess the pelvic floor. Transparent ultrasound can reconstruct and visualize the levator ani muscle. During delivery, an inappropriate relaxation, so levator ani coactivation, is a risk factor for having a prolonged second stage. Although we have a lot of information now and we have a lot of data, there are a lot of missing rings in our knowledge about both the correlation between delivery and pelvic floor damage, and vice versa, the pelvic floor function and dimensions and the outcome of labor. We do not really know how to prevent pelvic floor damage yet, although we have a lot of risk factor. We do not have reliable predictive models to know which women will have and which women will not have a significant pelvic floor damage. But definitely ultrasound is helping a lot in understanding our knowledge of the pelvic floor and its relationship with vaginal delivery and with pelvic floor dysfunction. And it is paving the way for a lot of interventional and corrective and preventive strategies to protect and the outcome and prevent the consequences of vaginal birth on women's health. So this is the end of the lecture of the pelvic floor, and actually this is my last lecture. So I'll be happy to answer any of your questions regarding the topic. I can see already that there is a question which I try to. I have no idea why it doesn't click. Yeah. So how to reduce the levator ani avulsion, and if happen, how to treat. Thank you, Dr. Rada. It's a very clinical and relevant question. So how can we reduce the levator ani avulsion? We do not know. I just answered it in the last slide. Unfortunately, some studies try to dilate the pelvic floor during the last phase of pregnancy. So there is a tool called the Epino. It's a balloon who is inserted in the vagina and then gradually dilated over many sessions. And the idea was that if you stretch well the levator ani muscle before delivery, this may associated with a reduced risk of levator ani avulsion. It does not work. Okay, so we do not know till now how to reduce it. Definitely, since the most important risk factor found in the literature is the forceps delivery, it seems that reducing the incidence of forceps delivery may help the reduction of levator ani avulsion. Of course, this is a very complex evaluation because forceps is also a useful tool in the labor ward in expert hands. So it's really a difficult question, and we don't have an answer to that yet. Dr. Adila is asking about the exact position of the probe to see the anal sphincter. Okay, I'll maybe I went too fast on that. Okay, so whereas in case of if you are doing the pelvic floor assessment of the levator ani muscle, we put the probe in the sagittal view, so in the midline. In case of to see the anal sphincter, you have to rotate the probe, so make it horizontal, and then angulate it from up. Okay, So this is the movement that you have to do it to see the anal sphincter. The assessment ideally of the anal sphincter is by 4-dimensional ultrasound. It's a complex technique and it was extremely difficult to include in the lecture. Shall we explain to all patients about the expected injuries before vaginal delivery? Well, thank you so much for this question. It's really a question which goes to the heart of the problem. Okay. Dr. Vidula Mukesh Bavish. So Dr. Vidula is asking, should we explain to the patient the risks that they're about to face in vaginal delivery? Well, it's a matter of debate, and actually it's a fight every time we talk about the risks of vaginal delivery. I believe that every woman, okay, planning to give vaginal birth, she does not only, she may be informed, she has the right, okay, to know what is she about to face. Okay? This does not mean that we should recommend doing cesarean section, absolutely. But if I put myself in the shoes of the woman, if I'm about to face an event, this event has a risk of giving me an injury of one of my important muscle of the pelvic floor of about 15 to 20%. I have a risk of 1 to 3%, depending on the center where you're working, to having an anal sphincter injury. Okay, I'm having a risk of increasing of having an anal incontinence. Okay, I think that I have the right to know it. Okay, so this is what I believe. There is no consensus about it. Okay, I have to say that going and giving lecture around the world, it's very uncommon to find centers in which women are informed about the risk of vaginal deliveries. But thank you very much for this extremely relevant question. Another relevant question by Dr. Adil Ashraf about the repair of the levator ani muscle in the labor ward. Well, the levator ani muscle is extremely, almost impossible to see the injury in the labor ward, also because in the vast majority of cases, the vaginal wall where the avulsion has happened is intact. Okay, so you cannot repair it in the labor ward. Okay, there are a small study on the surgical repair of the levator ani avulsion in after delivery. So women in urogynecological women, urogynecological patients, and it was the Australian group. They tried to expose the levator ani muscle, reattach it by a mesh on the pubic rami, and that did not give any improvement. Okay, and most of the cases after this correction, there was still evidence of the avulsion. So you are giving a risk to the patient, and we don't have any evidence that surgical correction of levator ani avulsion is of any benefit. Another extremely good question by Dr. Mukesh: how does a woman present clinically with levator ani avulsion after her delivery? The vast majority of women with levator ani avulsion after delivery are completely asymptomatic. Okay, sometimes some women do feel vaginal laxity. Okay, so a levator ani avulsion is associated with vaginal laxity, so subjective complaint of having the vagina which is much more lax than before delivery, and there is a significant difference in the symptoms of laxity in women with and without avulsion, but the vast majority are asymptomatic. The main consequence of levator ani avulsion is prolapse later in life. What percentage of such patients deliver urinary incontinence after vaginal delivery? There is no evidence that levator ani avulsion is associated with, well, there is no convincing evidence that the levator ani avulsion is a specific risk factor for urinary incontinence. Okay, we have found in our population a very small association between the crystalline maneuver and avulsion and urine incontinence, but I would say that levator and avulsion is mainly associated with prolapse and not urinary incontinence. Yeah, that's the state of our knowledge in the time being. Yeah. I would say that I covered all the questions, and thank you very much for also for your extremely interactive and relevant question, which means that I succeeded to communicate the findings and our knowledge on the topic, and that you are really extremely inside the topic, and that you understand the 360 degrees, the consequences and the depth of the argument. So I would stop sharing my my screen, and I think now the next lecture is Dr. Lakshmi Ravi, is that right? And she will talk about the understanding of the aneuploidy screening. Am I pronouncing the name correctly?
Yes, yes. Thank you. You are right, and thank you for that wonderful lecture. I was listening to yours, and now I'll. Can I share my screen to?
Yes, please. Thank you very much. I'm looking forward to it. I stopped sharing, so I think you should be able to share your screen.
Thank you, Dr. Alan. Thank you very much.
Thank you, Yassine, for the invitation. And yeah,
yes. Can you see the slides?
Yeah, I'm sorry, Dr. Lash, just
a lost
recognition yes. of and a thank you for Yassine for his organization and for all the other lectures, and which is really, I enjoyed it. It's an extremely rich course, and I hope that we'll meet soon again. Bye. Good luck.
Thank you.
Yassine, can I start?
Yes, Dr. B, you can start.
Oh, please. Okay, fine. So now, now we'll take you towards understanding the concept of aneuploidy screening. We need to understand that genetic chromosomal abnormalities are a leading cause of miscarriages and recurrent pregnancy loss. Every woman has a risk that her fetus has a chromosomal defect. The risk for many of the chromosomal defects increases with maternal age. And we now know that ultrasound is the main modality to document about the normalcy of the fetus. And considering the most common genetic syndromes, it follows with trisomy 21, 18, 13, Turner syndrome, triploidy, tetraploidy. And would now coming to the most common question, will ultrasound suffice to detect all these syndromes? So ideally, what are the pointers for aneuploidy in ultrasound? So when we do an ultrasound, the fetus can have some major fetal structural abnormalities. These major fetal structural abnormalities, especially when there is more than one system involved, multi-system anomalies, then they are a pointer of genetic abnormalities, especially aneuploidy. Then severe fetal growth restriction, severe early onset fetal growth restriction, you will see in trisomy 18 and triploidy. And you can have some soft markers for aneuploidy, which can mark towards or which can be a pointer towards aneuploidy. So, but we also need to understand that 40% of Down syndrome fetuses are absolutely normal on ultrasound. And see, when we speak of or think about other syndromes like trisomy 18, trisomy 13, they have a lot of other systemic abnormalities which can easily be picked up by ultrasound. But whereas in trisomy 21, there are only some very minor soft markers in ultrasound, and hence we need some effective screening test of how we can do the aneuploidy screening with the help of ultrasound. So what is a diagnostic test? A diagnostic test is a test which is 100% sensitive, and if you want an absolute chromosomal normalcy, that is, if you want to do you want 100% result for a Down syndrome, then it is only by an invasive testing. So a chorionic villus sampling is done between 11 to 14 weeks, where you take a small amount of placental tissue and then you subject it for analysis, whereas an amniocentesis is done after 15 to 16 weeks, where you draw 20 ml of amniotic fluid and send it to the lab for genetic analysis. So now, the results, you can either have a FISH, which is a fluorescence in situ hybridization, where you get the results in 2 days after 48 hours, and then you can get the routine karyotyping in a turnaround time of 3 to 4 weeks. So now, if we understand that the absolute test or the 100% diagnostic test is only going to be an amniocentesis, then whom do we offer this test is the next question. So if we think that we can, if you offer this amniocentesis to patients above the age of 35 years, then the Down syndrome pickup rate is only 30%. So 70% of Down syndrome babies were born in the low risk group. So what is the need of the hour? So, and whom should we offer this invasive diagnostic test? So now, ideally, we need to identify a subset of patients who are at an increased risk for Down syndrome, and then we have to offer this test. So what do we need now is a simple screening test. So now we are looking at one simple screening test, which we can offer to all, which we can give universally to all. Then from that particular cohort, you identify who are the high risk, who are the low risk, and then you try to offer this invasive diagnostic test only to those who are high risk. That's what we're going to do. So a screening test is applied to the general population. It identifies a subset of patients who are at high risk for Down syndrome. Screen positive result does not mean that the fetus is affected. It only means that a diagnostic test is indicated. This is very, very important when we try and do aneuploidy screening in the general population, because it is ideal that we make the parent or the patient understand, the woman understand that what we are subjecting her is only a screening test. The test results may come out as screen positive or screen negative. If she is screen positive, it only means that a diagnostic test is indicated, and it does not mean that her fetus is affected. So what are the tools for screening? In the first trimester, we have the nuchal translucency, soft markers like the nasal bone, ductus venosus, and tricuspid regurgitation. In the second trimester, you have soft markers. Coming to biochemistry, you have the double marker, which is the free beta HCG PAPA, the triple, quadruple, and now you also have the enhanced first trimester screening. So fetal aneuploidy screening, the changing scenario. So earlier, how did we start with? We only thought it is advanced maternal age. And then the triple screening test actually held the screening scenario for more than 2 decades. But now we know that this triple screening test is literally outdated, because it gives you a sensitivity of only 50 to 60%. But now we have better screening tests, and hence triple screening test. It is high time that we forget triple screening right now. Now you have a nuchal translucency scan at 11 to 14 weeks, which can give you a detection of about 70% if you do it alone. If you do a double marker combined with NT, your detection rates are high. If the patient misses first trimester screening and comes to you only in the second trimester, then you can do a quadruple test, or you can do the what is called as a genetic sonogram, where you look for the second trimester soft markers, where you get a sensitivity of around 70 to 75%. And finally, we stand now. This is a new kid on the block, which is a maternal cell-free DNA, which is NIPT, and that gives you a sensitivity or a detection rate of as high as 98%. Having this in mind, as I earlier told you, depending on what type of test you're going to offer, the detection rates are going to, the sensitivity of each test is different, but all of these tests are going to identify one group of women. They're going to identify who are the screen positive group. Once you identify this group of women, then they will be subjected to invasive testing. But the ideal one is you must select the test which will have an optimum, a nice detection rates. Like you can't now, that's why earlier I said it's better you don't go for a triple screening test when you have the quadruple in the second trimester. So you try to offer a test which has a better detection rates. So this is how the procedure is done. This is a chorion villus sampling where the needle is, where you just insert the needle and you take some amount of placental tissue. Whereas this is amniocentesis, you see the needle tip in the amniotic fluid and you draw amniotic fluid for analysis. And considering the detection rates of the screening test, as I told you earlier, the maternal age and the fetal NT and maternal serum biochemistry at the 11 to 13 weeks, which we called as a combined screening test, still holds good, and it is a universally accepted test which gives you a detection rate of as good as 85-90%. And if you keep adding the markers like nasal bone, ductus venosus, or tricuspid regurgitation, then there will be a slight increase in detection rates with lower false positive rates. So how did this evolve? Initially, after the Kypros Nicolaid's group, the Fetal Medicine Foundation, the evolution of the 11 to 13 week scan for the detection of the nuchal translucency, and that actually emerged as the most powerful screening marker, which is now transcended by the NIP team. Now, this 11 to 13 week scan combined screening test gives you a good detection rates, and that's now, this is the Nicolaid's pyramid of pregnancy care, where you ideally, at 12 weeks of gestation itself, you triage the woman, whether she is a high risk or low risk. And at that point of time itself, you will subject her to a specialist care if she's a high risk, or if she's a low risk, or if that means if she's screen negative for aneuploidy and the other complications in first pregnancy, then you will follow her up as a low risk. So the concept of the NT scan is a very, very old concept. That is, in 1866, Langton Down reported that in trisomy 21, the skin appears too large for the body, the nose is small, and the face is flat. So now, say the skin is too large for the body, the nose is small, and the baby has a flat faces. Now, what are we trying to do by in ultrasound? We are trying to identify phenotypic features of Down syndrome early by ultrasound. So see here, the skin is too large for the body, so there will be an increased nuchal translucency. You know that the nose is small, hence you may have an unossified nasal bone. And as you have the face being flat, you can have some markers for aneuploidy. So look at this. So you have a nice fluid accumulation here, so an increased nuchal translucency. As suppose here you can see the nasal bone nicely, whereas here the nasal bone is unossified. And so this is how you incorporate the phenotypic features of Downs as soft markers in ultrasound, and then try to incorporate into your screening protocol. The other markers are the nasal bone, ductus venosus, and the tricuspid regurgitation. So how do you do the nuchal translucency measurement? It is at the ground rump length between 45 to 84 millimeters. Only the maximum thickness of the subcutaneous translucency between the skin and the soft tissue overlying the cervical spine should be measured, and the caliper should be placed on the lines. So these are the basic criteria for measuring a nuchal translucency, and it is clearly available on the FMF website for you to go and obtain competence. You can submit the nuchal translucency images and obtain competence in measuring a nuchal translucency. Now, how do you image the nasal bone? To image the nasal bone, you need a mid-sagittal view of the fetal face. There, you will be able to see three distinct lines. The top line, which you see here, is the skin line. The bottom one, which is thicker and more echogenic one, is the nasal bone. So this is the skin line. The thicker, the second line tends to be more echogenic than the first line. There will be a third line that is in continuity with the skin, but at a slightly higher level, and that represents the tip of the nose. So this section is very, very important when you want to identify the presence of a nasal bone or not. So, and you always feel that this is also called as an equal sign, where you feel that the second line is more echogenic than the first line. But whenever you try and image the nasal bone, you always must be clear that you get a perfect plane. Then you will evaluate the nasal bone. Then what are we trying to do in screening now? So you're trying to pick up, to detect the maximum number of Down syndrome by adding more and more filters. So like you do serum biochemistry, you take biochemical markers, you look for the nuchal translucency, you add one more marker, and then what you do, you know what will be her a priori risk, that is her age-based risk. On that risk, you try to add all these markers, and then you will you will arrive at a final risk which says that she is screen positive or a screen negative for this particular condition. So this is so what happens, all these factors like serum biochemistry, the nuchal translucency are all incorporated into the software, into the algorithm, and the risk is predicted. So what happens in Downs, if you see, the beta HCG is increased and the PAPA is decreased. So this along with the nuchal translucency. So serum biochemistry, when you add it with the nuchal translucency, gives you a good detection rates. Whereas if you do not add NT and you do only this beta HCG and PAPA, then the detection rates would be slightly lower. The next point is, should you think, I do not know, because people keep on saying that, see, this is an abnormal NT, this is a raised NT. Actually, it is like how we should consider this is, each marker, it has no meaning if the risk prediction is not done using the specific likelihood frequency of 2 millimeters, then you have to convert it in terms of risk ratios by incorporating into the algorithm. And so only if the nuchal translucency is 3.5 millimeters or more. So anything less than 3.5 millimeters, then you simply use the value, the number into the algorithm, and then you go ahead with predicting the risk. But if for a nuchal translucency of greater than 3.5 millimeters, then the risk of chromosomal defects is very high. And the first line of management in such pregnancies is definitely offering them chorion villus sampling for fetal karyotyping. There is no sideline test when you have a nuchal translucency of 3.5 millimeters, and it is ideal you go directly for an invasive test. A detailed scan should be carried out at 11 to 13 weeks in search of major abnormalities and genetic syndromes. A detailed scan is also carried out a couple of weeks later, and you also do a fetal echocardiography. And then if everything is fine, then obviously the fetus may have a favorable prognosis. Now, once you think about aneuploidy, that means you must understand what is a likelihood ratio, because we all know that the values of the scan measurements, the blood test, the mother's weight and age go through a software that predicts the risk of having a baby with Down syndrome. So the estimate of risk will be mentioned as a ratio, that is 1 in 1200 or 1 in 70. The ratio of 1 in 1200 means that only 1 in 1200 women will have a Down syndrome baby. So the likelihood ratios for any test actually decides the efficacy of the test. Hence, we always should have a little knowledge, and an application of likelihood ratio in predicting the risk is very important. So I'll just take you to the very bare minimum basic things and to just try and understand what are we looking at. So the efficacy of a marker is equivalent to the likelihood ratio. So by screening, what are we trying to do? We are trying to filter. So the predictive value of each marker is different, as each one has a different likelihood ratio. Now, how do I make you understand what is a likelihood ratio? So I'll give you a case example, and then it will be very easy for you to understand. See, look at this image where you have an increased nuchal translucency, and then you also have all these things into a software. Then this comes out, the risk comes out as somewhere between 1 in 10, and then you do a karyotyping, and then you identify that this baby is going to be a trisomy 21. See, you can see three sets, three numbers here of T21, trisomy 21. And now you have some markers on ultrasound, and the baby turns out to be trisomy 21. So this is a true positive. I'll show you the next scenario. See, in the same way, the nasal bone is absent, the nuchal translucency is 3.3 millimeters. When you add these two into the risk incorporation software, you get a screening number of something like 1 in 20, and then you do a karyotype. It turns out to be normal. So, in this scenario, the markers are present, but the baby is normal. So, this is called as a false positives. So, likelihood ratio, positive likelihood ratio means true positives by false positives, and negative likelihood ratio means true negatives by false negatives. So, isolated likelihood ratio is nothing but the positive likelihood ratio of a marker multiplied by the negative likelihood ratio of other markers. So, as simple as it is. So, the addition of other first trimester markers to the existing risk ratio. So, you keep on adding these markers, then the risk ratio automatically gets modified depending on the likelihood ratio. And then you will end up in either a high risk or you will end up in either a low risk. Okay. So, what is the value of additional markers like ductus venosus and tricuspid regurgitation? Is it necessary that when you do an aneuploidy screening, you should go and do these markers for everybody? Obviously, no. If you can do a nuchal translucency or do a combined serum biochemistry, and you can do a good screening test, that itself is going to give you a sensitivity of 85 to 90%. So the application of the markers is only going to increase slightly the detection rate, but it will definitely decrease the false positive rates. So you can definitely, if this the protocol also says that you can add these markers only to the intermediate risk population, or if you're well versed in doing these markers, then you can add it to your screening protocol, but that depends on your institutional policy. So even if you do not know to do all these other things, if you know, if you're perfectly qualified or you know to competent to do a nuchal translucency and do a serum biochemistry, then that itself would suffice when you're handling screening. So how do you do this ductus venosus? So ideally, first you need to do the color flow mapping to demonstrate the umbilical vein, ductus venosus, and the fetal heart. So you have this aliasing area here, and the pulse Doppler sample should be small, somewhere around 0.5 to 1 millimeters, and that should be placed in this yellow aliasing area. For the tricuspid flow, you don't need a color flow mapping. You just get the 4-chamber view of the heart and place the sample across the tricuspid valve like this, and then you interrogate it to get the first tricuspid regurgitation. Excuse me. So now I'm just going to show you the normal and abnormal waveforms. These are the technical criteria which you need to evaluate the ductus venosus and the tricuspid regurgitation. Sorry. Now, once this is a normal waveform for you, always it is the reversal which is considered as a positive marker in the first trimester. Now I'm going to take you towards serum biochemistry. This is the first trimester dual marker, that is PAPA beta HCG. This is what you're combining with NT. This is the triple marker, AFP, estriol, and beta HCG. This is the quadruple marker, AFP, estriol, beta HCG, and inhibin A. Now, what is very, very important when you do serum biochemistry is first, you need to have an account. Why? Because the ultrasound dating is very, very important because these markers are dependent on the gestation age of the fetus. The moms actually differ according to the gestation age. So that means you do a quadruple screening test, but there is a difference between the LMP date and the ultrasound date. That means if the BPD and the FL values are not correctly entered, then there is a high possibility that the quadruple screening test may go wrong. So every time you have a result in your hand, you need to check whether the dating of the pregnancy is right, especially when they have taken a serum biochemistry, and whether the right parameters have put inside, only then you can rely on the test. So that's one thing which we need to understand when we do a serum biochemistry. And for the quadruple, you use the BPD and FL values for correlation. The next thing now is to this group, now you have this addition of PLGF and enhanced first trimester screening. And that is another new option because now this preeclampsia screening has come inside. And now you can also add PLGF to aneuploidy screening that is also available now. So this is how this report comes out as if you have incorporated the nuchal translucency inside, you have incorporated the beta HCG values, the PAPA values, and now you have incorporated all these and then you get a screen positive result like this. So now says screen positive and the Down's risk is 1 in 7 in this pregnancy. So now you have a report like this. Now what is that you're going to offer next? So obviously you're going to tell her, see now the fetus runs a high risk of T21 and also you have a low PAPA value. So not only will this fetus be followed up for aneuploidy, we'll also track you for serial monitoring of growth. And when you offer her an invasive testing, I'm just showing you the test result. See, this is a normal karyotype. So this is just to tell you that even when the risk ratios are 1 in 7, whatever it is, the next step is simply to offer an invasive testing and to act upon the result. But there is no way that, because this generally happens in the population. The minute you give a result of a screen positive, she becomes so confused and she decides she becomes so confused and she decides to go ahead with termination of pregnancy rather than going with an invasive testing. So this should not happen. And ideally, a pre-test counseling is very, very essential. Even if you do a simple test like a quadruple, it is better you counsel them prior and then offer them the test. Now I'll be taking you to a few slides on NIPT because that is the assessment of fetal DNA in maternal blood. And we all know now that NIPT is a good screening test because it has a high detection rates of as high as 90%. And because it is detected early in gestation, probably after 8 weeks of gestation, well and good. These tests can be offered early in gestation itself in a truly high-risk population. So this is the sensitivity and the specificity of the test. And you see that the detection rate for T21 is 99% for a false positive rate of 0.01%. So this advantage as a screening test because of its high detection rate and a very low false positive rate. But we also need to understand that NIPT is not a diagnostic test. It has high sensitivity and specificity, but we always have to do direct fetal sampling and karyotyping to be done for confirmation. So this we need to understand. Sources of error will be very early gestation age, maternal obesity, multiple gestations, low PAPA, and you must always check for fetal fraction. In an NIPT report, if the fetal fraction is less than 4%, then it is we do not know whether we can rely on that report, because you must have a sufficient fetal fraction. Only then you can rely on the NIPT report. So ideally, this was the policy statement which they said that the ultrasound markers indicating increased risk of aneuploidy, or if there is a history of prior pregnancy with trisomy, or if she is screened positive for aneuploidy in combined first trimester or second trimester screening, then go for NIPT. So each one actually has a statement of their own of whom you have to offer NIPT. But we need to understand its limitations first. It is limited to diagnosing T21. It is specific for T21. It cannot detect unbalanced translocations, deletions, duplications. It does not screen for single gene mutations. And the turnover time for NIPT is somewhere around 3 weeks. And NIPT is not indicated for fetal structural anomalies on ultrasound. If you see a structural anomaly on ultrasound, there is no role of NIPT. And obviously, multiple gestations now, of course, NIPT, some groups are still using it, but in vanished twins, known genetic anomalies, NIPT is not that good. And cell-free DNA testing is an excellent screening test with higher detection rates and low false positive rates, but it cannot replace the 11 to 14 week scan or the first trimester combined screening test, because the 11 to 14 week scan is an anatomical scan. We survey the fetus, because you can very well go and do an NIPT for anencephaly. So you just can't move away the 11 to 14 week scan, because that is now becoming a very, very important scan in antenatal care. And it should not be a part of a routine prenatal lab assessment, but should be an informed choice after a pre-test counseling. And ideally, the most ideal way is it can be offered to patient with increased risk of aneuploidy. That is the intermediary risk group between 1 in 100 to 1 in 1000. That means you offer a combined screening test. If the test results are greater than 1 in 1000, yes, you say she's low risk and leave her off. If it is less than 1 in 100, yes, obviously you're going to offer her invasive testing. Somewhere between 100 to 1000, you have the intermediate risk category where you can really use this NIPT. So ideally, when you come to aneuploidy screening, you need to offer aneuploidy screening to all, because it should be a universal test. You should not consider the first trimester screening only to high risk patients. That means you should not first trimester screening only, for example, only for advanced maternal age. If you're going to do like that, then your detection rates will not be high. And it is ideally that you cannot interpret with a single NT value. It's not possible. You ideally should interpret the value with the risk ratios. And we always need to follow the right technique while we are measuring the nuchal translucency. And if you ask which test has a high sensitivity, obviously it will be the first trimester combined screening. And you can consider the options of NIPT for the intermediate screen group. Once you understand this, now I'll take you towards the second trimester soft markers. Now I have told you about the 11 to 14 week scan and how do we handle aneuploidy screening at 11 to 14 weeks. Now, the second trimester soft markers. So what are soft markers? So they are sonographic findings that are generally not abnormalities by themselves, but they are indicative of an increased risk of an underlying fetal aneuploidy or some non-chromosomal abnormalities. So we'll go to soft markers one by one. I will just start with the case scenario so that you will understand the importance of the soft markers. So this is a 35-year-old second gravida who presented for scan at 15 weeks of gestation. So at 15 weeks of gestation, we felt that the bowel was so echogenic as the bone, and also the nasal bone was imaged, but it was not that echogenic. It was not more echogenic than the first line. So because of the presence of echogenic bowel and the unossified nasal bone, or we were not very clear about the ossification of the nasal bone, maybe it is hypomineralized. And having in mind that she is a 35-year-old second gravida, so obviously we said you need counseling and further evaluation. But somehow she came back at 20-week anomaly scan. At the 20 weeks, everything was fine, and this turned out to be a down baby at term by after when later on. So we just want to understand that all markers may not be seen in all cases. Markers may be transient findings. Each marker has a different sensitivity. And we need to understand that the technique of looking at the marker, the interpretation and effective counseling, all these things are very, very important at the end of the day. Because if you see an hypoplastic nasal bone or an absent nasal or an unossified nasal bone, how do we counsel? Or if you see simply an echogenic intracardiac foci, or you see some renal pylectasis, or then how do we counsel? This is very, very important. We need to understand what is our stand when we see these soft markers on ultrasound in mid-trimester. So this was the older soft markers and the likelihood ratios, where they said that the nuchal fold actually had a high risk for downs. But please do understand that this list, this nuchal fold, the short humerus, short femur, hydronephrosis, echogenic foci, echogenic bowel, major defect, this risk likelihood ratios are totally outdated. We have a new list by Agathocleus, and this is the newer markers, and these are the markers which are now included in the mid-trimester ultrasound scan. You will understand that the absent or the hypoplastic nasal bone runs a very high risk of an isolated likelihood ratio of somewhere around 6.5 in mid-trimester. And you also see the addition of new markers like the aberrant right subclavian artery, ventriculomegaly, and all others are the same. You see that the nuchal fold does not carry the same weightage as it carried earlier, and so the markers of importance now, the newer one is like this. So the first one is unossified nasal bone, followed by an aberrant right subclavian artery, followed by minimal ventriculomegaly, then followed by nuchal fold, and followed then by echogenic bowel. And pylectasis, echogenic intracardiac foci, and the short femur are now completely losing its importance as aneuploidy markers for downs. So you to understand changing marker relevance. So short humerus, short femur, echogenic bowel, isolated nuchal fold, all these things are actually the as an isolated marker. When it is present as an isolated marker for predicting downs is low, but when you have absent nasal bone, ARSA or mild ventriculomegaly, then even if it is isolated, then the presence of the marker does change the risk ratios for the woman. Now I'll take you towards other markers like a choroid plexus cyst. So we all know that it is insignificant finding. An isolated CP cyst is fine, nothing to worry. But if this isolated CP cyst is seen with other markers, then you must think about T18. So I'll just show you. So there was a bilateral choroid plexus cyst. You see how the fists are clenched, persistent clenched fists. The baby is unable to open its hands. A single umbilical artery, a rocker bottom foot, again bilateral renal pylectasis, and you see that this was a fetus with Edwards syndrome, but no major anomalies on ultrasound. So that is the importance. See, you see the T18 here, you see three here, and this is T18 Edwards syndrome, and that is why you can very easily miss this out also if you really do not give the due weightage to the markers. But I also want to tell you this. Whenever you say that there is a marker, what happens? There is a feeling of uncertainty about the normalcy of the fetus. There is a fear of undergoing an invasive testing and the cost involved. And most often, the pregnant lady does not understand that something is, she only feels that something is wrong with her fetus and she only wants an answer, it is yes or no. But ideally, it is we who have to take our time to counsel these women that these markers are per se are not going to cause any harm to the body or to the fetus. It is only that we need to incorporate them into a risk ratio and then make them understand what is the risk for aneuploidy and then offer them an invasive testing. So now when coming to the last few slides. So you see a routine, you're doing a routine mid-trimester scan. If the mid-trimester scan is normal and you have no markers at all, so fine, the aneuploidy risk is reduced actually by 30%. But if there is a presence of a marker, say for example, you do a mid-trimester anomaly scan and there is an unossified nasal bone. So what are you going to do? So first you go and check her records. Has she done a first trimester screening ideally? If she has done a first trimester screening, then what you have to do is you take her modified first trimester screening risk as her a priori risk and then apply the marker, the likelihood ratio of this marker to that particular risk number. And then you obtain a modified risk from the first trimester. And then depending on the risk, you can counsel her. Here, what happens if there is no first trimester screening, then you can modify it directly based on her age-based risk, or you can modify it based on after her quadruple test results. So this is how you handle if you see a marker in the mid-trimester. The next point is relevance of these markers in the light of first trimester screening needs evaluation. See, for example, if this woman had undergone an NIPT for some reason, and then she has a marker in the mid-trimester, is it going to be important? So, I'll just give you the answer for that also. I'm just trying to explain to you how we handle the risk ratios. So, for example, this is a primey with 22 years, and she has an unossified nasal bone. If she has undergone a first trimester screening, then her risk ratios will be 1 in 27,865. Then I'll add the likelihood ratio of the marker into this number and I will get a ratio of 1 in 1,200. But if she's not undergone first trimester screening, then I'll use her age-based risk and then I will get a mark. Then I will identify a risk number from this age-based risk. However, this is the issue of consensus statement which says that the so-called genetic sonogram, which includes looking for soft markers of trisomy 21, should not be performed in women with a normal NIPT result due to its high false positive rate and poor positive predictive value, which means because you have an NIPT result with you, which already has a very good detection rate of about 98 or 99%, so we need not be worried if there are going to be additional markers in this lady in the mid-trimester. So coming to the last few slides, how do we implement an effective screening program? So the referring clinician, so all of them, all of the healthcare workers are very, very important if we want to implement an effective screening program. The referring clinician must know whom to offer, what test to offer, and when to offer. That means this should be a universal screening test. Considering what test to offer, the ideal period will be the 11 to 14 week scan, and the one which is in your institutional protocol, the best one which is ideal for everybody would be the combined screening test, which is the nuchal translucency with the serum biochemistry. Next thing, the scan center or the laboratory, they have to be very careful on the technique of the test, on the interpretation of the test results, and you generally need to audit your own data of your own. Like for example, if you're going to get the license for the nuchal translucency in the second year, obviously the FMF would ask you an audit of your data to see whether you are interpreting it the right way. The last thing is the feasibility of doing an invasive testing for screen positive patients. So do we have a fetal medicine unit nearby where these patients can be referred for invasive testing? And finally, the patient. So an effective pre-test counseling has to be done to the patient even before offering a simple test. And you have to take time to understand, to make the patient understand, because interpretation of the test results are very, very important. And that is how we can implement a very effective screening program. So what I have told you now is just a drop in an ocean, but I hope I have covered all the basic concepts of aneuploidy screening, and thank you so much for this opportunity. Do I have any questions to answer?
Thank you, Dr. Lakshmi. At the moment, not yet. Maybe in 1 minute.
So nice. No questions means you have all understood everything. Oh, fine, great. I have a question to answer. And if double marker is low risk, whether to do quad test or not. Wonderful. Thank you so much for asking this question. See now, ideally, I told you, you need to offer a test which has a high sensitivity. Now you have offered, by meaning double marker, I'll take it as a combined screening. That means you have offered a nuchal translucency combined with a double marker. So that sensitivity of the test is 85 to 90%, and then you got a low risk. Now, why offer her a quadruple risk, which is only 75%? So no, you should not do that. Once you have a risk, once you have given her a good test and you get a low risk in the test, stop aneuploidy screening with that. Don't keep on adding that. You can add if you have an integrated sequential screening system. It is not available in so many countries, and hence it is better we do not do it. Can we predict preeclampsia through these markers? Okay. You can predict preeclampsia by adding uterine artery Dopplers. You can add serum biochemistry, you can add maternal age, and you can identify, you can have a risk for preeclampsia. So the next time if I have an opportunity, I will take you through first trimester screening for preeclampsia as a separate lecture. Oh, thank you so much, Dr. Mukesh. You liked the talk and you said there is good clarity. Thank you so much. Madam, what is the role of a duplicate screening in recurrent? No, I do not understand the question, Jyotisna. Can you please, in aneuploidy, can you please unmute yourself and ask the question so that I can answer you? Jyotsna, can you? Oh.
She corrected and she wrote, sorry, unemployed.
So are you speaking about a double marker? Is that what you're trying to speak? Okay, I'll get back to you. I'll just answer the next question in the meantime. What is the right interval between NT scan and double marker blood test? Ideally, I tend to do it on the same day, but because it is better, because it is CRL, nuchal translucency, and double marker. If you can do it within 2 to 3 days, well and good. But generally, I do not schedule one visit for the double marker and one visit for the nuchal translucency, because that only makes the screening more cumbersome. And secondarily, you do not know if you're going to take a week or a 2 week more, then the CRL will change, the nuchal will change, then maybe the screening is not that effective. So generally, I prefer make the patient come once to you, do the NT scan and finish off the double marker. Or within next 2 to 3 days is great. Role of aneuploidy screening in recurrent pregnancy loss. Okay, now I got the question, Jyotsna. See, the concept of recurrent pregnancy loss actually covers a lot many conditions. That means a recurrent pregnancy loss can be due to an APLA, or it can be due to any other conditions other than aneuploidy. But aneuploidy screening needs to be considered as a universal screening protocol. In recurrent pregnancy loss, you're also not only going to scan the fetus for aneuploidy, you're also going to look for all other causes of recurrent pregnancy loss. What is a cutoff nuchal fold measurement in the mid trimester? In the mid trimester, generally we take it as 6 millimeters. Okay. So thank you, Dr. Poonam, for that you like the talk. Thank you so much. Any other questions have I left out, Yasin?
No, it's all right then. Thank you very much, Dr. Lakshmi.
Thank you. Thank you so much.
So we'll go for break for 50 minutes, doctors. So after when we'll come back, then Dr. Mala will take her lecture. So it's 5:30 Dubai time, so we'll come back 5:45. Thank you.